who's from York St John's University. I've known Alex for a very long time. He did his undergraduate degree when I was doing my PhD, and then once he completed that, moved on to do his masters at Bedfordshire, and has subsequently gone on to do a PhD up in Scotland, and is now based up in York as a lecturer in exercise physiology. So this will be a great presentation for those that love all things heart physiology and cardiac physiology. So I will hand over to Alex in a moment. Just before then, if you have any questions for Alex, if you could add them to the chat function, or as well hold your questions to the end. I'm sure we will do a 10-minute Q&A at the end, which we can ask to Alex at that point as well. So I'll hand over to Alex.
Well, thank you very much, Jeff. Thank you, everybody, for having me. It's a shame that I couldn't down to kind of where it all started and give it a talk in person, but virtually it has to be. So again, I'm delighted to come today and present to you some of my work that's been mainly as a consequence of my master's, as Jeff alluded to, and also my PhD, which is mainly set around cardiac function, mechanics, and exercise through the ages. And I've been lucky enough to work on a number of different projects with various people, which is added to the profile of that aging profile. So just to give a brief background to my journey so far, really. I mean, I know Jeff just touched on a few parts, but I started my undergraduate at Bedfordshire in 2011. I did sport and exercise science. I then stayed on and did my master's by research in 2014, where I started to really gain interest and a focus on using ultrasound. I then made my way up to sunny Scotland to do a PhD in 2015, which I then finished in 2019. And then I settled somewhere in between, where I've been a lecturer at York St John for just over 2 years now. So I'm a lecturer there in sport and exercise science, and also have an active role in research there. So as part of my role at York St John, when I first we decided to try and set up a physiology research group. This has we made this up from the ground, really, and we didn't really have much resources. And as you can imagine, and I'm sure it's the same for everybody, we've been quite limited with how much research we can actually do in the last year. So we formed the Physical Activity and Cardiovascular Health Research Group. And collectively, with 3 of us, myself, Dr. Sophie Carter, and Amy Campbell, who's just recently joined us, we cover all things from sedentary behaviour, physical activity, all the way up to athletic populations, and cover all things cardiovascular health. So mainly using ultrasound aspects and physical activity assessment to look at heart side of things, and also the vasculature as well. So just to give you a broad overview of my research today, and I've predominantly, as I said, used ultrasound to focus on the populations of adolescents moving through to adulthood and then into older age. And I've studied this alongside exercise training as a way to look at athletic, say, performance and the physiological adaptations that come as a consequence to that, but also as to how we can use exercise to try and mitigate some of the age-related effects as we get older. So on the right-hand side is an image, an ultrasound image of the heart, which, just to cause confusion, it is left to right is back to front, and it's upside down. So most of my work is focused on the left ventricle, but we've also started to pay a bit more attention to the right ventricle as well. Not necessarily in my PhD, but some of the work we've been doing in the pediatrics, which I'll touch on shortly. So I'm aware that not everybody that's joining us today is from a cardiac specialism or from a cardiac background. So I just wanted to give a little bit of an introduction to try and keep as many people with me throughout the presentation as to what I mean by left ventricular mechanics, which are often broken into 2 different strands. So the first strand often concerns ventricular strain. And what we mean by this is it gives us a measure of deformation as the heart shortens, and then as the heart lengthens during contraction and then relaxation. So we can measure this in different planes of motion, different slices, if you like. So the first one, and this is probably the most widely known one, is longitudinal strain. So it measures the change in length as the top portion of the heart, which we call the base, and the bottom portion of the heart, we call the apex, move closer together. So this signifies a shortening as contraction happens, And then with relaxation, the heart expands and it begins to lengthen again. We can also measure in a different plane, which we call circumferential, which looks at the change in the circumference of the ventricle during that contraction phase. And as a consequence of both that, the shortening in the longitudinal plane and the reduction in the circumference, we get a conversion of mass that causes a radial thickening, so that the tissue becomes thicker. Throughout this talk, I'm mainly going to be discussing longitudinal strain and not so much circumferential, and I'm not really going to talk about radial today. The other strand of ventricular mechanics is what we call twisting mechanics or rotational mechanics. So not only does the heart squeeze and shorten, but it also rotates. And just to make this even more complicated, it happens differently at the top portion, the base, and the apex. So the base during contraction will rotate in a clockwise motion. The apex will rotate in the opposite way in a counterclockwise motion. So what we can then do is look at the difference between those two planes, so the top and the bottom, and we get a measure of the total amount of twists that the heart's undergoing. And to provide an analogy to this, it's very much like bringing a cloth to squeeze out the water. You wouldn't just hold both ends and push them together and squeeze, you would twist it. And that's the way the heart works in a similar mechanism. To try and gain the maximum efficiency, it has this rotatory motion. And this is the consequence of the myocardial fibers that run opposing angles from inside to outside. So how do we measure this then? So we use a technique called Speckle tracking echocardiography. Often looks very pretty with lots of different colors, but what it essentially does is we take an ultrasound image, we put it into some software, and we identify the key markers around the ventricular wall. And it measures the amount of deformation. So in this particular example here, from the point just before contraction to the end of contraction, the heart shortened, which is signified by the negative value here, by 18.5%. This is an important indicator as well, and it's often used in clinical purposes where those with stiffer hearts or dysfunctional hearts have a reduction in this shortening. So in order to get the rotatory aspects, what we do is we flip the probe in the opposite way and take a cut through this valve here. And what this gives us is a bird's eye view looking down. So in this particular image here, you can see the ventricular wall as a circle all the way around, and this is the valve here, so looking from top to bottom. And we do the same thing also at the apex, and from this we can get that amount of rotation at the base, the top portion, and the apex at the bottom portion. So then when we take a look at what we call a twist time curve, we can see this a little bit clearer. So we have the purple line, which represents the basal rotation, and then we have the turquoise line, which represents the apical rotation. And you can quite clearly see from here that they're rotating in opposing directions. And then when we take the instantaneous difference at each of these time points, you can see the peak twist occurs here. Now this AVC, represented on the graph, signifies aortic valve closure, which gives us an indication of the end of systole. Okay, so as the heart starts to twist, it increases here, reaches at about peak where the end systole happens, so the end of the ejection phase, and then it starts to unwind itself as it gets ready for the next contraction to then happen. So this figure here, or this graph, represents one cardiac cycle. And we can see a similar thing for this longitudinal strain that I was talking about a minute ago. So we see it as a negative value because it's getting shorter, 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 reaches the peak at around about here, which would be 26.2%, and then it begins to lengthen again. We see this portion here, and this becomes quite important as I talk about Asian research that we've been doing, where there's almost like a slight plateau, and it's clearer on the next slide as well, prior to the atrial systole, which then pushes it back to its original starting position. Some of the other additional analyses that we've been able to do with advancements in this Speckle tracking are related to layer-specific strain. So we know the heart is made up of multiple different layers, and we can measure this in the endocardium, the innermost layer, the mid-myocardium, the central layer, and the epicardium, which is the outer layer of the heart. And this is just the same whether it's longitudinal, or whether it's circumferential. We can also look at it from a temporal perspective as well. So much like in that twist time curve that I just showed you a moment ago, this is some data that I collected during my PhD, looking at the reproducibility of taking a scan, then doing a scan 10 minutes later to look at whether it's a reproducible method of looking at temporal analysis. So we can see the shortening happen here. And then we reach this point where there's that slight plateau of the diastasis period, mid-diastole. And at this point here, we get the atrial systole, which causes this load, which pushes it back prior to the next contraction taking place. Okay, so moving on to some of the work then. So everything really started during my MRes, so my Masters by Research. Those of you at beds, I'm sure this equipment here is very familiar. And we really wanted to look at the effects of both resistance-based exercise, in which case we looked at a single leg extension exercise at various different intensities. So we did 40% and then 70% of MVC, maximal voluntary contraction. And we also wanted to look at it in the same individuals in terms of dynamic or aerobic exercise, where we looked at it at 30% and 60% of maximal workload. So we produced a paper from this in EJAP, and we found that some of the data in terms of the aerobic mechanics, so that twisting, tended to increase from rest to exercise, which we know happens. And then it reached a bit of a plateau from that point onwards. And so Eric Storr's work as well has demonstrated that we see this plateau at about moderate intensities, at least in recreational people anyway. But we didn't actually see the decline in twisting that we would expect. Typically, some isometric hand grip work has shown that we get this reduction in twist, which is probably because of a heightened blood pressure response. Given the fact it wasn't a sustained contraction, it was only a 15 seconds, may explain some of the reasons as to why we didn't see those changes. And then I also recorded some data looking at circumferential strain, and we wanted to look at that amount of shortening both at the basal segment and the apical segment. And interestingly, we showed that the response to aerobic and resistance exercise altered that regional response of the apex or the base. But it was this work really in regard to the, sorry, I lost my point there. The aerobic exercise and this cycle is often used for stress echocardiography. Got my interest a little bit more. So when I moved up to Scotland, we then did a study without ultrasound at this point, to look at what happens if we start to tilt the body. So often we tilt the body over to the left-hand side to improve image quality. So if we put someone on this cyclogometer in the semi-supine position, but without this lateral twist or lateral tilting, do we see the same response at both a fixed workload and also at a fixed heart rate, or at least the same heart rate when we tilt people over? This has got important implications for practice, because if they did, it means we could freely move people to benefit image with the confidence that we know any cardiovascular changes remain the same at that particular workload. But what we actually found was that as you tilt the body over from that central position over to the left, the demand for exercise becomes greater. So we see increases in heart rate, rate pressure product, VO2, and efficiency tended to decrease. So practitioners really should probably just be a bit mindful in the trade-off between gaining good image quality and ensuring that you get consistent responses if you make slight adjustments in that tilt angle. Okay, so moving on to some of the athletic work that we've done in terms of exercise. So I was lucky enough to be asked to be involved with this project from Professor Unithan in terms of pediatric athletes. And the project was really focusing on trying to characterize some of the left and right ventricular adaptations in elite level soccer players. So we recruited 22 participants of both soccer players from English academies. So these were pre-pubertal kids and also controls. What we found was that wall thickness and end diastolic diameter, so structural adaptations, there was no difference between the athletes and the controls. But the athletes did show greater end diastolic volume and stroke volume. So greater volume differences between the two. So when we start to look at the strain measures, it was interesting to see that we didn't actually find any differences in longitudinal strain. And we know this is a marker or represents a decent marker of systolic functioning. So we couldn't quite understand to begin with as to why with increases in ejection fraction and we've got increases in stroke volume, so i.e. greater ejection out of the ventricle, but this doesn't seem to be the consequence of greater shortening, at least in that dimension. But then when we look at circumferential strain, so in a different plane of motion, we can see that this strain was greater in the soccer players and the controls. We also saw that they had this greater amount of twisting, which was the consequence of differences at the apex without differences at the base. So we're seeing regional differences in these rotation markers, and the fact that longitudinal strain didn't differ, the increases in or the greater strain in difference and also greater twisting might provide some insight as to why ejection fraction and the stroke volume were higher. So I've recently just had an article accepted in EJAP that has now started to look at the right ventricle. So again, the same group of pediatric athletes. We've started to look at the different levels now, not just the top and the bottom, but progressively down the right ventricle, so from here. But if we took all of these markers together as almost an average to get global value, we found that there were no differences between the groups. But when we break it in to the base, this top portion, the midsection, and the apex, we identified lower strain, right ventricular strain in the soccer players. Now that seems to be the complete opposite to what I just told you in regards to the left side. And we're not entirely sure why there seems to be this left and right sided mismatch. One potential reason is that these athletes did actually show larger diameter from this point here in the mid segment. So perhaps with it being more, say, bulbous, this changes the fiber angle of the outside wall and in turn might alter the longitudinal strain. Make the fiber angle more horizontal rather than vertical, that's likely to influence that longitudinal strain. So it requires more study, but it's interesting to note that if you just take this global value, it often is going to hide any regional differences or segmental differences that may be there. So moving on to some of the work then in terms of adults. So as I moved up to Scotland, I decided to do a systematic review. This is off the back of some of my MRes work where the ideas kind of stemmed from. So there have been many studies, but the consensus in the area seemed to be quite heterogeneous. So there didn't seem to be any general consensus around different types of activity and also different training levels. So we set out to try and investigate this a little bit further using two different methods or two different models. So we first based it off of a dichotomous classification of looking at predominantly endurance athletes against predominantly resistance, and also the training level effect of that. So whether they were being described as predominantly competitive or described as being elite level athletes. But we also wanted to use the Mitchell's classification, which to break down this crude assessment of the traditional method a little bit further by characterizing the percentage of static component of that given activity, and also the relative percentage of dynamic activity. So for example, a triathlete would be highly static and highly dynamic. An endurance runner would be highly dynamic but have low static. A weightlifter would be highly static but low dynamic, and a golfer would be low dynamic and low static. So it provides a little bit more of a detailed assessment of the type of activity. So in terms of longitudinal strain, we didn't see any differences between the athletes and the controls, whether that was with all types of study combined, or when we broke that down using Mitchell's classification or the training type or level. And we think this is quite interesting because although we didn't find any differences, what this does give us is some indication that if athletes present with lower longitudinal strain, which we often know is accompanied in disease states, this might be an important differentiator between what would be classed as a physiological adaptation and some sort of underlying pathology. So in terms of twist, again, we didn't see anything when we combined all of the studies in the overall effect, but the the effect was heterogeneous. So when we investigate the traditional and the training limitations, this is where we started to reveal some more differences. So granted, there's only a few studies, and this led us to think that we need more studies in these different categorizations to fully understand things. The endurance competitive athletes, there's no overall effect, but the elite endurance demonstrated lower ventricular twist, meaning it favored controls. The twist was greater in controls. What this means is we're not quite sure whether this represents a functional reserve or whether it represents a mechanical dysfunction, the fact that this twist is lower. But then when we compare that to the resistance exercises, they had greater twist than the controls. So this is the complete opposite to the elite endurance. And again, we're still not exactly sure as to why that may be the case. Perhaps, as I was alluding to earlier, in terms of this twisting that tends to be lower with increases in blood pressure or increases in afterload. If individuals are subjected to that chronically again and again in a repeated manner, perhaps the heart compensates by increasing this twisting mechanism. Now that's similar to what we see in hypertensive patients, whereby they present with a chronic increase in left ventricular twist. So again, more work is needed in resistance athletes, but it's interesting to know the training and also the modality of exercise in terms of the adaptations. Okay, so moving on to the aging problem then. So this is where our PhD really started to take a focus. So the issue that we're currently facing as both a nation and worldwide is that we're getting older. Those added years don't necessarily mean that we're living them in good health. So it's important that we maximize the health span as much as we can. So the period of life that we live in good health. I think some of the latest statistics from the ONS demonstrate that those who are 60 years of age, they spend the remaining years of their life, 50% of their life, in poor health. So it should be a nationwide objective to try and find strategies that can improve that health span and reduce the poor health quality for those people with their remaining years. So just to provide some context to what happens to the heart as we get older, we tend to see these differences in diastolic function, so the period of the cardiac cycle where the heart fills. So what we often see is that this peak E wave, which represents the velocity of blood as it travels across the valve from the atria into the ventricle, tends to decrease with aging. In contrast to that, we see a progressive increase in the A wave, which represents the velocity of blood crossing that valve after the atria has contracted. So what signifies that there's greater atrial contribution to filling, meaning the heart is unable to do it under its own esteem, being able to generate a pressure gradient between the atria and the ventricle to draw blood in itself. And to try and put those two measures together, we can look at the E to A ratio, which gives us a good indication of that. A value greater than 1 would signify more dominance of the early inflow, whereas a ratio less than 1 signifies greater dominance of this A wave, and that the atrium is having to contribute more than the ventricle can pull its own, draw the blood in itself. But interested in healthy participants at least, we don't see an age-related difference in ejection fraction, so systolic function. So the heart has to preserve the ejection phase for as long as it possibly can. Now this changes as we go from rest to exercise, but we do see some notable differences between systole and diastole. So what we then wanted to do is to start to delve into the masters athlete a little bit more. So we recently stated that the masters athlete may be viewed as a unique non-pharmacological model, which may allow researchers to disentangle the inexorable from the preventable effects of aging on cardiovascular health. So what we're essentially saying is, can we use the masters athlete as the extreme end of a spectrum in those that are involved with competition and often types of physical activity and exercise to understand what can be prevented and what's inevitable part of the aging process. So after the first meta-analysis, I always said to myself, I'm never going to do another one. And then I find myself 6 months later on PubMed doing another search. So I was aware that there was a large body of literature around exercise in older adults, particularly moving from 45 years of age upwards, so encompassing that middle age and the older age groups. But there was no systematic review or meta-analysis that had been conducted, so we were quite surprised. So we kind of jumped on the opportunity to conduct one. And again, what we looked at was the differences in the structure and the function. At this point, mainly looking at some of the conventional markers, so those inflow velocities I was talking about, the E to A and E to A, just because of a lack of research around the twisting mechanics and particularly the strain as well. So what we was older athletes had larger LV dimensions, mass and volume, and these represent normal physiological adaptations of the adult. So this was an unsurprising finding, really. There were no differences in systolic function, so ejection fraction, longitudinal strain, of which there was only 4 studies, and fractional shortening. And this is perhaps not that surprising because we were focusing on healthy individuals. And I've previously just said in the slide before that we don't really see differences in ejection fraction associated with aging in healthy participants. So there might not be anything to kind of recover. But we did see that the athletes had greater stroke volume. So if ejection fraction is the same, contractility through longitudinal strain is the same, the larger stroke volume is probably the consequence of just having a bigger heart to begin with, a larger end diastolic volume here, so a larger volume of the heart. In terms of diastolic function, what we really found is, just focusing in on box number 6 here, is a greater ratio of both inflow velocity of what I spoke of before, and also what we call E to A prime, which runs on a similar basis, but rather than inflow, it looks at how quickly the tissue, the wall moves up and down. So the observed differences in LV structure, systolic and diastolic function in older athletes are maintained during advancing age. And we looked at this using meta-regression. So for those of you who aren't familiar with some of the processes involved with a meta-regression, it runs very similar as your standard regression, except each data point represents an individual study rather than an individual participant. So what we wanted to do was to see whether these observed differences between athletes and controls in the structure, and more notably in terms of diastolic function, persisted from age 45 upwards. And it appears that they do in the large majority of cases, but more particularly the E to A ratio, which was a flat line and maintained all the way across. So older athletes seem to have superior cardiac function during those advancing years compared to their least active counterparts, at least. So if we turn to some of the LV mechanics then, in terms of the twisting, what existing literature suggests is that there's progressive increases in this twisting from young, middle-aged, and into older age. The influence on longitudinal strain is a little bit more equivocal, with probably a 50-50 split. Some showing that there are reductions with age, some showing that it's preserved with advancing age. So one of our PhD studies then set out to look at this a little bit further in terms of exercise and masters. So we took 4 groups of males. So we had 2 young groups. One was trained, endurance trained, and one was sedentary. And we had the same for the older guys, where we had masters athletes who were involved with regular competition, and we had older sedentary healthy adults. And it was quite challenging to try and gain those older adults, because with age often comes with a multitude of cardiovascular risk factors and associated problems. So we tried to tease that out, which often meant that we probably had more of a recreationally active sample in order to get that healthy population. We really wanted to look at the cardiac mechanics. So the paper that just up there in terms of EJAP, which we recently published, was focusing on ventricular strain. So what we showed was that we found no influence of age or training status on any layer-specific strain. So from the endocardium, the mid-layer, or the epicardium. So in terms of that twisting that I said a moment ago that seems to increase progressively with aging, there's long been a hypothesis that that's the consequence of a reduction in function in that middle layer, but no one's really explored them at the same time. So we showed In our data, there were no differences in this endocardial strain. But then with the use of the temporal analysis, so up here, we just focus on the figure A, we started to notice differences in this diastolic phase as opposed to the systolic phase. So this dotted line here represents end systole. So anything to the left of that represents systole, so the contraction. So the heart is shortening, 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 reaches its peak there, and it begins to lengthen. The solid blue and red lines represent the older athletes, and they reach a point where it stops shortening and it then plateaus during mid-diastole. It then doesn't reach its 0 point prior to the next contraction until the atria has contracted. So it seems to potentially, we think, be stiffer, which would make sense in terms of some of Ben Levine's work around compliance and volume pressure curves. Whereas the younger guys tended to decrease. So this is getting longer and longer as the heart's returning to its original shape. And it doesn't reach that plateau point until later, which means for a given percentage of diastole at the same time point, the younger heart has lengthened further. Okay, so it may be because it's a little bit stiffer. And we saw similar things as well in terms of the expansion of the ventricle, particularly at the apex. So in terms of this circumferential here, it's not expanding to the same extent in the same time as what the younger heart is doing. So looking at some of the twisting then, so this is some unpublished data which we're currently working our way through. I just need to find the time to write it. What we tended to see was that we saw an increase in twist from the young guys, the young untrained group here, to the old untrained group. We saw an increase which concurs with some of that earlier work that I showed you. But what we also found was that the older trained individuals, there was a lower twist, and this was to similar levels of the young individuals. So exercise seems to mitigate the age-related increase in twist. So then we started to think about what could be some of the reasons behind this. It can't really be because of differences in endocardial strain, so function of that inner layer, because I previously said to you that the strain wasn't different. So whether the strain measure isn't an appropriate measure of endocardial function, or there's alternate mechanisms out there. So we've recently turned our attention back to these to this temporal analysis and these twist time curves. Now what we typically do is measure the amount of twist from the 0 point to the highest point of the twist. But this part of the heart, or this part of the twist curve, often gets neglected. And this really started to draw our attention. But when we look at it from there, it's actually where it begins to twist in this direction is actually lower than the 0 point. So should we really be measuring from that point up to this peak of twist? Well, some of our preliminary data does suggest that there may be age-related differences, and then account for that early phase, that early systolic phase, provides some mechanistic understanding as to why we may be seeing age-related differences. So just to put this into a little bit, to provide a little bit of background to this and how we've started to apply this technique through speckle tracking and taking it from its application to the heart and moving it into the arteries. What the software does is it zeroes the point based on the ECG. So at the QRS complex, the onset of ventricular depolarization, it zeroes this point here. But there's a slight timing mismatch between ventricular function or output and the effect on the artery of whatever part of the artery is being measured. So we're particularly interested in the carotid artery in the neck to look at the expansion. But you can see here, it's zeroed at this point. The carotid artery is still recoiling. So it's still coming back to its original point at this point. So again, if we measured it from this 0 line here, we get an uncorrected strain, which would be here. But actually, we should probably be measuring it in terms of the strain and the amount of expansion of that vessel wall at the point that it starts to change direction. So it starts to come from recoiling to this point here where it's back to its original size, back to its original shape, and then the pressure wave hits and then it starts to expand. So really we should be shifting this curve upwards to this 0 point to get a value of the corrected strain. And by looking at the difference between this onset point and the point that the vessel begins to expand, gives us an indication or an indirect measure of the pulse transit time. So the time that it takes for the pressure wave to exit the ventricle and reach the particular site that you're measuring. So from a statistical point, what we can see is this is the peak strain here, and it's a positive value because we're looking at that expansion of the carotid artery. But then when we look at the corrected strain, we can see it's significantly higher. So just by using the standard approaches of the Speckle tracking and applying it to the artery, we significantly underestimate the true strain of the artery itself. So where do I think we should go next? So I think we need to go back to the exercise stuff. The majority or all of the data I presented to you there is related to resting differences between athletes, controls, young and old. But we don't really know what this then means. So I think we need to explore it further with exercise. Now with ultrasound, that comes with its own issues because ultrasound during exercise is particularly difficult, especially at those higher levels. So whether this is in athletic athletes, so that lower twisting I was talking about in the endurance elites, does that represent a functional reserve at rest? Are they able to supplement that and improve stroke volume even further as exercise intensity increases? In terms of aging, if their twist happens or there's greater twist in the older individuals compared to younger, does that limit the functional reserve and therefore potentially functional capacity? I think we also need to look at alternative forms of exercise. So we've started to look at some high intensity interval training in the aging population, but there's relatively a lack, particularly in regards to these twisting mechanics. So I think we need to move away a little bit from the conventional methods of exercise, especially more to say high intensity. And we also need to look at females a little bit more. All of the literature that I presented to you today was in regards to male, and there's a paucity of literature in females. Definitely needs to be studied more, whether that's in younger athletes or from a health-based perspective as we move through the menopause and into older age. And also the exercise type, I think there needs to be a big pull on more resistance-based studies. Again, there was only 3 in that meta-analysis that I presented, and the majority of the aging-based literature is in aerobic as well. So I definitely think there needs to be more of a pull towards resistance-based exercises. So that brings us into the mechanical battle. So do we use strain or do we use twist? They do represent different things, so I think they supplement one another. In terms of the aging study that I showed you, we seem to see different responses in strain and twist during systole and also diastole. So we saw differences and effect of twist during systole, but we didn't in strain. And then we saw strain-related differences that were specific to diastole. And then also peak and temporal. Peak is great, gives us an indication of the highest values, but temporal just offers so much more, being able to take a step back and look at some of the underpinnings and the mechanisms that come before or either after those peak values. And who should we study a little bit more? The majority of my work's been in healthy individuals, and I think we need to branch a little bit out in terms of the wider population. So my study focused very much, or one of my PhD studies focused very much on healthy aging, which we defined as those without any diseases, try and improve our internal validity. Our external validity and generalization suffered as a consequence of that. But the World Health Organization defined healthy aging as the process of developing and maintaining the functional ability that enable well-being in old age. This means individuals can opt to be accompanied with those cardiovascular implications. So I think we're to appeal to a wider population rather than just an aging group that are able to stay healthy while being relatively active, creates a very niche group of individuals. So I think we need to match out a little bit more, but of course that comes with the connotations of introducing other confounding facts. And finally, just acknowledge the people that I've managed, been privileged enough to work with it. The work I've going to do to today really wouldn't have been possible without many of these people. Professor Sculthorpe, Professor Fergal Gray, Professor Vishnunathan, currently supervised me during my PhD and really guided my development during my latter years. And Dr. Richards, who really started this process on the verge of quitting university until a second-year module introducing ultrasound, which completely flipped everything on its head. And again, all the people right who I've just been lucky enough to work with and who have helped and supported all of the way. So thank you very much for listening. I hope I managed to keep everyone on board. I appreciate it does get technical at times, but if you do have any questions, please feel free to email me. To handles there as well. Not that I think the interest in, but I do with more followers. That would be much appreciated.
Brilliant. Thank you very much, Alex. That was really, really interesting. And I'm sure there'll be a lot of people on this presentation that would have gained a lot from this. I will open open it up to questions now, because I know there's a lot of budding clinical physiologists. I can see Joe's turned her mic on, so I'll let her ask the first question.
Thank you, Jeff. Thanks, Alex. It was absolutely brilliant. I thoroughly enjoyed all of it, which you might not find very surprising. So, Alex, do you want to take your slides down? Can you do that? And then I can bother you more. Oh, mind you, you'll probably want to come back to them later. So, Alex, all my questions, all of them, how long have you got? So basically, I'm going to ask some things with some of my students in mind. So you answered a few of them as we were going along. So a couple of things I was going to ask about whether you thought we needed to carry on working at rest or like imaging at rest, or whether to do it during exercise. And you answered that in regard to the aerobic exercise. But you know that obviously my area of interest is the resistance exercise. Do you still think that's a plausible measurement after because you obviously haven't gone back to that since the King Com in Bedford?
Yeah, I absolutely do. I think it just needs the right stimulus. So I think that I think it depends on the type of activity. I know it's looked clinically using an isometric hand grip, but for me, that might give you an increase in an afterload, but it doesn't really represent a practical activity you would probably do because it's sustained minutes. So Eric Dorr has done some work at double leg press, and observances in strains and the temporal in terms of the time-related aspects of change, the decrease and recovery. I think it needs to be sufficient stimulus, but applicable to a true activity rather than just hand grip.
Yeah, I agree. So yeah, we're starting to go down. Well, we still use the King Com, etc., but we're trying to do things during the exercise. So my other question is, there's obviously a lot of strain and a lot of twist. The more up to date measures, but you see, you were still presenting significant differences in mitral valve inflow, so the E and the A waves. Yep. Do you think that you still need to ensure that you collect standard echo measures whenever you're doing a study, or would you just worry about your strain and your twist measures?
You have to record them in time, because I think that they, especially for the diastolic function, I mean, I didn't touch on it because it would just be too much otherwise. But as well, to the twisting, you get twisting, which often drives that pressure gradient and that drive from the atria to the ventricles. Really, that's the mechanism around this inflow. The inflows, I think that the mechanical stuff gives you more insight to what's happening during the actual action and relax, as opposed to a consequence of, but they're still important. So for ejection fraction, for example, gives you an indication of the percentage of blood ejected. That's the surrogate pump function, as in it's happened after the contraction. The twin strain gives here and then as to what's happening during the contraction itself. So I think it comes down to the problem with echo is that you get so much data. It's what goes into papers and what should be studied and what shouldn't. But I think that it should at least be aligned. So if you're looking at diastolic, you should still be looking at inflow velocities as well as the mechanical aspects.
And are you now? Yeah, I completely agree. I think those standard measures are still so informative. And then finally, now that you're investigating the right ventricle as well, are you always looking at both together, or do you look at them like thinking, going back to the publishing, do you see them as two different entities when you're?
I think it depends on the level of analysis and the reasons being. I mean, we kept it as two separate papers because having peak temporal segmental levels, having left and right for publishing purposes just would have been far too much. And then we felt we would have lost a lot of the novel aspects, which particularly the right ventricle was that segmental strain.
Yeah.
But I think if the purpose is to look at biventricular at the same time, I mean, I think we will probably look again at those data because the left and right seem to show different adaptations. But again, we didn't look at longitudinal strain of the left side at each of those layers, each of those levels, sorry. We did the right ventricle. So I think yes, but it depends on the purpose and how much data there is, so it doesn't lose the main messages.
Brilliant. Thanks, Alex. I thought I'd get us going. I'll let somebody else ask a question.
I wonder if I can stop sharing just so I can see people.
There you go. Cool.
There we go.
And does anybody else?
There we go. I can see people now.
Does anyone else have any questions at all? I'm just going to quickly check the chat, and I can't see any questions in there. But does anyone else have any questions? If you do, then add them to the chat, or please turn your mic on. I'm just going to ask one question, as there seems to be nobody at the minute, but I'm not going to ask you basically a physiology question. It's more just about your sort of career, etc. And there's a lot of people in here which are budding clinical cardiac physiologists. What's the one bit of advice or a couple of bits of advice maybe you'd give to those people who were in the same position you were maybe 5-6 years ago?
Good question. Obviously, every experience is very different. In terms of, say, supervision, I had very good experience with all of my supervisors, which made everything a lot easier. In terms of the practical aspects of, say, doing a PhD, it's not without its challenges, and I definitely faced some during my PhD. So just to provide some insight, we had a series of studies planned, which involved cross-sectional studies, longitudinal studies, and we were in the process of acquiring a new ultrasound. So we held off, hence why I did another meta-analysis when I said I wouldn't do one. And we were told it would arrive in, I don't know what it was, about June, July time. Comes August, September, October, November, nothing. Then the guy arrives, no ECG leads. So we couldn't actually start testing until the January, February. So I'd almost lost an entire calendar year of doing no data collection, which meant we had to revamp all studies and go back to the drawing board for, completing one, if not two studies, and how we could maximize the amount of, data and chapters and outputs from that. So my advice would really be is just keep engaged. And yeah, it's really difficult knowing or not knowing different situations. But for me, I had a relatively smooth process in the sense of the support I had. But yeah, it's not about the challenges, but just persist. Make sure it's something that you enjoy and you're invested in. And it makes it a lot easier from that point. And try and work with as many people as you possibly can, and take different. Not every opportunity is necessarily going to be aligned with your research. Like I've started to do some more around golf and well-being, but it's in a line that starts with that aspect, and then we've got further developments that's going to be related to cardiovascular function further down the line in terms of caddies and golfers and what have you. So yeah, just take any opportunities you can is what I would suggest.
Fantastic, thank you very much for that, Alex. A couple of questions have just come in here from Abby, so I'll just start ask you those if that's okay, because apparently she has no voice. But with the functional changes in E-A ratio with aging, do you see structural changes in the atria? And are there significant increases in atria diameter due to that increase in A-wave velocity? If you want to, you can probably see it in the chat if you want me to repeat it again.
Yeah, no, that's fine. I've got it. That's fine. Yeah, so in terms of my data, I haven't actually looked at any atrial stuff. So that's a whole other data set that we've got to try and explore as well. In terms of some existing data, typically we do see an increase in atrial diameter with aging, which would likely contribute towards a greater fin pressure because of that atrial contract or that atrial contribution at least. So I would definitely focus on the atrial measures as well. That's, again, everything really stemmed from the left ventricle, and the right ventricle and atrium are starting to gain a bit more attention. So if you are going to do an ultrasound scan of the heart, I would recommend doing it so that you can at least capture a 4-chamber, and you can then get atrial strain and ventricular strain in the same time, if you're collecting data as it is. So it's definitely something that's worth looking at as well in terms of diameter and also strains, if that answers your question, Abby.
Brilliant. And one final question.
Sorry.
One final question from Abby is: are atrial? Oh, she has got a voice. Are atrial measures somewhere we should focus in future in aging populations?
Yeah, I think so. You know, the atria comes before the ventricle, and I know that sounds daft, but if we're going to look at the events that contribute towards ventricular stuff in terms of output and stroke volumes, cardiac outputs, we should definitely focus on the atria as well, for sure. Just as I said there, that if you're going to capture the left side, you might as well capture atria and ventricle at time, because you do it in the same image. But it's definitely an area that requires more study for sure. So yeah, I would focus on that as well. If that answers your question.
It does. Sorry, Collaborate froze on me. So I think that is it. I don't think anyone else has got any further questions. I think we're just approaching the hour, so I think we'll wrap it up there. But thank you very much again, Alex. Really appreciate your time. And this is normally where you get a round of applause from the room, so you'll just have to imagine that for the moment. But thank you again to everyone who attended. And next month we have another talk from a guy called Mike Hempsill from the States. He'll be talking more about sociology sides of sport. So I will let you all leave, guys, and thank you again for attending.